Hello and welcome back to our talks, and we are going to continue the talks on pancreas today. In the first one we talked about the pancreas, history, anatomy and function. In the second one we talked about acute pancreatitis. So continuing the sequence, we will talk about chronic pancreatitis today. So how do we approach a case of chronic pancreatitis? Remember ISIC. I is to identify early stage pancreatitis. S is for screen for complications. Implementing treatment plans is I, and then again C is for care coordination. Let's come to C first. What is care coordination? Care coordination means that you are going to coordinate with different multi-speciality teams to treat pancreatitis. And for that, you need a lot of doctors around you, that is gastroenterologists, pain management specialists, then you need endocrinologists, and then you need rehabilitation doctors, and finally some dietitians. So all these coordinated effort will treat a patient of chronic pancreatitis, and that is what is necessary for treating pancreatitis. We will go into the clinical phases. So that's about care coordination, and now let's go and identify the factors which are early stage chronic pancreatitis. Mind you, it is not just the pain that is a relevant point here, because sometimes you won't have pain in chronic pancreatitis. And if you have pain, that might be very unrelenting pain. So it's very unlikely that your serum amylase and lipase are not prognostic. I'm going to just enumerate in brief the most important differences. The amylase and lipase are not even prognostic or diagnostic markers in chronic pancreatitis. So what happens is basically an acute pancreatitis got resolved, it's what you think, but then it happens again and keeps recurring. So that is, finally it becomes a chronic pancreatitis. So, identifying, when we talk about the symptoms, what are the symptoms? Like we started with, you have pain. Now, pain can be no pain at all, maybe, or if there is pain, it's not classically starting in the epigastric region and going to the back. And if there is pain, you might even find the patient lying on the bed with his knees up to the chest. It's so painful sometimes. So unrelenting pain. So these are basically the differences what we are going to see here. Followed by, you might have diarrhea. The stools are very kind of you have a distinguishing features of these stools, that they are oily, they are fatty, and what the other thing what you can see is that sometimes you are not able to flush these stools down. Now that becomes a characteristic feature of pancreatitis. So what kind of stools are we looking for here? We're looking for oily, fatty stools that are difficult to flush. Then you have nausea, vomiting, and then you have severe belly pain, as we talked about, and you have weight loss, and then you can have other complications such as a mass in case of a pseudocyst. So this is basically the symptoms what you're talking about here. But the classical triad is your pain, nausea and vomiting, and fever. So this is the classical triad what we get in this case. And also there is other symptoms that we can have which might point towards pancreatitis, is that you have pain, then you have exocrine insufficiency, pancreatic insufficiency, and finally you have diabetes mellitus. So these are the different types of classification signs. Then you have Tykar O scoring, this classification system. And that includes your toxic or metabolic, idiopathic, genetic, autoimmune. Then you have recurrent or acute, severe acute pancreatitis. And then you can also have obstructive symptoms. So this is the basic Tykar-O system of classification. Okay, so we have done the symptoms. What are the causes? Should we talk about a list of causes? I think we talked about a lot of causes in the acute pancreatitis. So in cases of chronic pancreatitis, what could be the list? The list is most common, 70% of the cases you'll get is alcoholism. We'll talk about why alcoholism. What does alcohol do to the pancreas? even if it does it slowly, what does it do to the pancreas? And then first is like 70% you have alcoholism, then you have cystic fibrosis, autoimmune, then you obviously have hereditary, then you have your smoking, and then you have gallstones and lupus and medicines, hypercalcemia, hyperlipidemia, and finally you have chemotherapy. So these are the causes of chronic pancreatitis. So we talked about pain, we talked about symptoms, and then we'll now come to the. So what are the etiopathogenesis? What is the etiopathogenesis behind chronic pancreatitis? What are the theories behind chronic pancreatitis? Main two causes what we can think of, what is mentioned in the texts, are impaired bicarbonate secretion, number one, and number two, due to genetic or alcohol influences. So impaired bicarbonate secretion, what happens is that in which the secretion of the pancreatic juice, the bicarbonate production doesn't match the secretion of the pancreatic juices, so that ultimately leads to formation of plugs within the pancreatic ducts, and that causes finally leads to calcification and stone formation there. So that is one of the reasons. The second is your genetic and alcohol influences. Alcohol decreases the ability to respond to calcium signaling, and that alters the feedback mechanism, it says, and which finally leads to a cell cycle causing the death of those cells there. So that is one of the reasons why it is said that alcoholism, 70% of the patients, the main cause is alcohol. So it's not a good thing to have overall. Never mind, let's continue. Now what happens is that what are the tests we are looking for here? As I mentioned before, amylase and lipase are not prognostic or diagnostic markers. There is one called fecal elastase 1. So values of these are more important than your qualitative fat fecal tests. Qualitative fecal fat test and your fecal elastase 1. So these are the two enzymes to look out for besides your natural lipid profiles and liver function test and CBC and metabolic tests on that. So inflammatory markers also play a role here, like ESR, CRP, ANA, and anti-nuclear antibodies and rheumatic factors and immunoglobulins there. Finally, MRCP, yes, it is. And ERCP, definitely it is a traditional test, and especially when there is no steatorrhea and plain films are not showing any calcification, so that is important. Then duodenal aspirates are also good enough. They are the output of pancreatic bicarbonate, amylase and lipase, so that is duodenal aspirates can be helpful. You can do it with the same setting as the ERCP when you do that. So what is the goal of treatment now? The goal of treatment is decrease the pain, improve the malabsorption, stop alcohol, quit smoking. So these are the things which you are looking for. And surgeries, if it is inevitable, then you have to perform them. Then that is pancreatic abscess, fistulas, pseudocysts, ascites, mechanical obstruction of CVD, stenosis of duodenum, and vessel bleeding due to splenic vein thrombosis. What is the differential diagnosis? Differential diagnosis of chronic pancreatitis would be, then you have peptic ulcer disease. Now that is, you should be glad you have a peptic ulcer rather than a chronic pancreatitis, if it comes to that. But hopefully you don't have anything if you stay away from alcohol and all these. Cholelithiasis, biliary obstructions, colic, acute pancreatitis, pancreatic malignancy, then you have pseudocysts, chronic mesenteric ischemia. So these are the differential diagnosis. A good thing, a very good thing what I can talk about is the prognosis of chronic pancreatitis. People believe that it's a nasty situation, but if you look on the brighter side, if you have it, there is a 10-year survival rate of 70% in chronic pancreatitis and a 20-year survival rate of 45%. A 20 years of after having chronic pancreatitis. And then there is, unfortunately, people having alcohol, there is a death rate of 3 times larger in chronic pancreatitis. And 30% of the patients will develop diabetes mellitus in this case. Finally, what are the complications? What we can have in chronic pancreatitis is your pseudocyst, recurrent acute splenic vein thrombosis. Then you have pseudoaneurysms, diabetes, and these are the problems. So anybody you have, any patient of yours, you can just start off with a low-fat, high-protein diet and then some supplements to overcome the malnutrition. So this is all about chronic pancreatitis I can tell you about today. See you again next time. Thank you.